Hi everyone, my name is Amanda Hunter. I chair the Together Social Care Cabinet Work Group at the Together Declaration, and I'm here today to introduce you to the third in our series of discussions on NHS excess deaths. The first of these discussions was streamlined on the 17th of January, and we had an excellent panel, including Patrick Pullicino, Reverend Patrick Pullicino, who will be joining us again today. In that first session, we looked at the NHS end-of-life policies and practices that we believe are a significant factor in the thousands of people who died during lockdown in care homes and hospitals across the UK. We believe that these practices are a continuation of the Liverpool care pathway, which was officially banned in 2014, but we believe has still been practiced and driving policy within the NHS. And today, I'm going to introduce you to Patrick Pullicino again, and we will be discussing some of the protocols that were brought in during that time, namely NG159, NG163, and NG191 during that period, which we believe are behind many of the excess deaths during that period and since. We believe that these protocols, although one of them has been replaced now, are continuing to drive policy. And this is something we will discuss in my interview with Patrick Pullicino. We will also be looking at how we, the public, can fight back and join together in solidarity to try and stop these practices and to call for a serious review of these protocols. Now, Patrick Pullicino is a retired professor and consultant neurologist. He's now a priest, and he's going to be, as I say, he's going to be talking in detail about some of these protocols, and we'll be showing us some of his slides. Now, Patrick Pullicino was very active in getting the original LCP, the Liverpool Care Pathway, banned in 2014. It was banned because it was believed to be barbaric, and it was fast-tracking the elderly and disabled to early deaths. People were being put on these pathways way before their time. And Patrick agrees with us that he believes these policies are still being practiced in the NHS and they need to end. So we'll be talking to Patrick Pullicino now. Thank you very much.
So briefly, I'm a retired neurologist, and I was a professor in Canterbury and consultant neurologist down there. In 2009, when I was working in Canterbury, I took a patient off the Liverpool care pathway, and he survived 14 months until, unfortunately, again, he was put on the Liverpool care pathway at another hospital and died through that. But in those intervening 14 months, he was a grandfather, active. Well, he was in bed mostly, but he was looking after his, playing with his grandchildren. So, this really opened my eyes to the fact that, diagnosis of somebody dying as he was supposed to be was a sham, really. And I wondered how many other people around the UK this was happening to as well. But I looked into it a little bit, and I realized there was no way that people could make a diagnosis that somebody was dying. There was no scientific way to do it, and if you tried to do it, you were basically fooling yourself. And so the press, I don't know how, the press started to look for cases like this, and particularly the Mail, and several cases came up in the Mail, and then people came forward until the Minister Norman Lamb decided to set up an inquiry, which he did ask me to attend with another 8 people, palliative care as well as clinicians. And it led to the Neuberger committee, and the LCP was discontinued in 2013. And it was good to have had the Neuberger report and for the discontinuation, but it was very clear at that time that everybody's saying, oh, well, it's not really a fault of the pathway, it was applied badly. Really wasn't the case at all. There were fatal flaws within the pathway. The most important ones that were people were diagnosing when somebody was dying. That was still, it was something that people got into their heads somehow. Maybe it came in from palliative care. And the second thing was dehydration, particularly. And so anyway, these pathways stopped for a while in 2013. I remember there was a gap in the hospitals, a lag where you saw, no palliative care teams coming around, but then it crept back again. And whereas the LCP had been very carefully documented, every year they would put out a report, statistics, how many people were on it, etc. And that stopped. So although the pathways came back, they didn't have the name of LCP, and nobody knew where they were, how many were going through it, etc., etc.
Can I just ask you a question?
Sorry. Yes.
Yeah. About that. Do you think that do you think there were other protocols that were being introduced under the radar, or do you think that this was because the precedent had been set that became practice, and it was kind of then embedded in the culture?
Yeah, I think it was the practice. It was in the culture, and it really did what they wanted it to, and it was, nobody was going to reinvent the wheel when this worked for what it did. And I think hospitals were under terrific pressure because of beds, particularly the elderly. The elderly spend a long time in hospital. At the final admission, when somebody comes in, and then if they die naturally, they tend to spend 5 weeks on average in hospital. 5 very expensive weeks, and 5 weeks where they need a lot of nursing, a lot of medication. So these were taking up a lot of beds. Obviously, it's normal care for elderly people, looking after people who are very sick. But the LCP was then seen, I'm sure, as a useful shortcut, and that there was pressure on hospitals to start to use this pathway, particularly because the whole system had been geared up to it. So,
and there were also financial incentives, weren't they?
Definitely, because it's like £500 a day per bed for a patient like that, plus if they're in intensive care, etc., etc. So there are a lot. There's a lot of savings. So anyway, the way I continued after that, I realized this was coming back, and I still tried where I could to talk about it. And I did attend. People asked me to attend best interest meetings sometimes when they said, "Oh, my relative is being put on this medication. Could you come? I have a best interest meeting." So I would go along. And I think quite often, if you have a medical person there who knows a bit about what's going on, the best interest group usually backs off and gives the patient another chance. So I found those useful meetings to go to. And
yeah, but those families were very, very, very fortunate to have you. So many families don't even know what's going on. They really do not, and they trust.
Well, that's right. You could see that they didn't know. They thought they were being, they thought they were being looked after, but there were obviously some people who knew exactly what was going on. Some relatives knew exactly what was going on, tried their best to stop it, and some of them were successful, some of them weren't. But
of course,
anyway,
these practices, with the introduction of NG163 and 191, which we'll talk about later, NICE guidance during the pandemic, these were rapid guidelines for COVID patients, but it seems that this guidance was being used to fast track people to early graves in care homes and hospitals. And often, and we have evidence of this from whistleblowers within care homes, and to a lesser extent hospitals, where they were saying that, you know, the patients and the residents were being drugged up on antipsychotics to keep them quiet. And also, you know, in a dementia care home, you know, people with dementia wander. And so to keep them isolated in their rooms and to keep them quiet, because obviously they weren't seeing their families, they were very distressed. They were drugged up on lorazepam. I mean, my mother, for example, was drugged up on lorazepam. I didn't realise until later. And she was comatose every time I visited her. You know, I was lucky to have 1 hour a week, 7-hour round trip.
They didn't tell you that she was on lorazepam?
No. They told me that she had been given something for when she was having personal care to sort of calm her. I thought it was something quite innocuous. I didn't know it was lorazepam. And the problem is that dose was not changed in 2.5 years, despite the fact that my mother went from a size 12 to a size 6. She became a skeleton. And we know that from other reports from families, very, very similar cases. And we have reports from, as I say, care workers who said that in their care home, you know, these antipsychotics were given out like Smarties. And obviously, when you're drugged up,
it's sad, really. The
yeah,
thing
when
is,
you're drugged up, you're not going to want to eat or drink, are you? Because
no, exactly, or drink. And
yes,
well, one of the issues that hasn't been addressed properly by the NHS is the huge number of it's the number of elderly that there are nowadays. You know, the demographics have just taken off. And while this has been happening and the elderly have increased, the actual NHS beds have been halved, would you believe? Over the last 20 years, the NHS bed number has decreased by 50%. You know, go figure what's happening. And well, maybe there, you know, a lot of nursing homes have been set up, but that it, you know, it needs to have a whole national, it needs to be a ministry of its own looking after the elderly in hospitals, in care homes, making sure that they're looked after carefully, making sure that they aren't diagnosed as dying as soon as they come in the door. You know, that's our country, the elderly people. They've contributed so much, and they can continue to contribute.
yes, and absolutely. And yes, I was talking to Eileen Chubb of Compassion and Care about this last night, and you know, we were thinking these remarkable lives. People are still in their 90s contributing to society and you know, enjoying their lives to the full. I mean, not everybody's going to be fortunate enough to live that long and have that, you know, quality of life, but you know, that is not the issue. I mean, during COVID, you know, people were being refused resuscitation if they were over 65. They were being put on clinical frailty scales, you know, and if they were above 5, they were, you know, being put on end of life.
You know, it's you know, how that ever happened, goodness knows. Goodness knows. Anyway,
well,
so
I think it, you know, there was an exercise which was called the Nimbus exercise that Matt Hancock denies ever was put into practice. But during that discussion, they were talking about the fact that doctors were asking for the permission to prioritize care, and that they knew that that was very controversial and would be for the public because it could lead to thousands and thousands of excess deaths per week. And did they have permission to do that? So I think they denied that exercise was ever put in practice. But when you look at what happened, and we saw it on the ground in care homes, I think that was definitely happening.
Yeah. Well, so just to finish that slide off, it's I was wondering what I could do. So with another couple of doctors, we set up this website called Dehydration Lifeline, which is still ongoing. And if anyone wants to look at it, dehydrationlifeline.org, and it teaches you how to diagnose dehydration, teaches you or tells you what can happen, what to expect, how to attend a best interest meeting, and there's some legal forms on the online too. So hopefully some help to some people who find themselves in a situation like that and have nobody to turn to.
Well, that's very useful, Patrick. And, you know, at Together Social Care on our end of life campaign team, we are in the process of putting together some guidance for families of what to look out for, you know, and what forms they should fill in, what forms they shouldn't fill in, you know, around the abuse of DNRs, for example, which during the pandemic and since have been used as a shortcut, you know, shorthand for do not treat at all and put on the pathway. And we've even seen, you know, documents actually showing the flow chart of that. You know, there was one from the Resuscitation Council, I think it was, and it showed a flow chart, and it said, it was COVID rapid guidelines, and it said, DNR in place, yes, end of life pathway, end of life care. And then on the other side, it said DNR not in place, and there was a treatment pathway. I mean, you couldn't get clearer than that.
No.
People, you know, and when my mother was put on, had a DNR, I suggested that they were using that as a short track to put my mum on end of life, because my mother was not end of life. As you know, my mum lived 14 months after I was managed to get her out through the court of protection. But she actually lived 3.5 years after the first diagnosis. We were told that she was dying. 3.5 years. So I entirely agree with you that, you know,
3.5 years. I mean, that's 3.5 years of
when
good life. I mean,
yes, exactly. Well, my mum's life was not so great, but that was her choice, you know, and it must remain the choice of the person concerned, or where they lack capacity, their family. You know, these decisions should not be made, you know, by people deciding to play God. You know, in the case
that's
of the
exactly as you say. That's exactly what's happened.
Mm-hmm.
People, I don't think they intend to play God, but what happens is that there's become this whole sort of groupthink that yes, we know best what's best for people, we know best for them, and yes, the best for this person would be an end of life care pathway, in quotes, which is really euthanasia. So, you know, it's sad, but it's crept in the back door into the NHS.
Yeah. And it's very much here to stay unless we fight back against this, I think, and we push back against.
We must, and we are, and we will, and it will be defeated, because there are too many people. It's too important a thing, and you know the truth will win. But we just have to keep going on at it, and not be turned back, and not, you know, not say, oh, you know, they will win. No, they will not win. This thing will
and
grow.
I agree with you. We must not give up, because far too many lives are being ended prematurely. And it's not just the lives, obviously, of the people who are lost, but it's the devastation and the trauma that is caused with the
devastation, trauma, guilt. You know, so many people feel so guilty because they were there, they suspect something's wrong, but they don't push hard enough because, you know, they're speaking to professionals. And then afterwards they say, well, I should have done more. You know, if I'd done more, then my relative would have been alive. You know, and it's a terrible guilt to carry around with you. Anyway.
Yes, and I was talking to a gentleman this morning, one of the cases that we're looking into, and he was saying that it's completely divided the family, because he could see the writing on the, you know, the cards, so to speak. But the other family members couldn't, and you know, said, well, the medics know best. And he was saying, well, I think in this case, no, you know, but it's caused rifts within the family. You know,
I've seen that too, because then some part of the family is usually closer to the relative than other parts of the family. And, you know, those that are not close may be quite ready to accept what the hospital, those who are close, no, they know what the truth is.
Yeah, and they know their loved one. You know, I knew my mum wasn't dying 3 times. They tried to put her on the pathway 3 times. So anyway,
well done to you for standing up to it. So, all right, so just a few insights. They're pretty straightforward ones, though. But first of all, end-of-life care is effectively a form of euthanasia practiced throughout the NHS and in care homes. And people have stayed and tried to pull back from this. But the fact that it happens so much, so frequently, and so many people die from it means you cannot give it any other name, you know. Now, the crux the crux of end-of-life care is somebody making a diagnosis that a person is dying. And this, you know, this is the thing that we have to try and get rid of completely, because once you say somebody is dying, It's like a self-fulfilling prophecy. You know, you try less for them, you don't give them so much of this, you don't. And in reality, just like your mother's case, you cannot tell. If people make the diagnosis, and like my patient's case, they make the diagnosis, and so many other cases I've seen, you cannot. And it's not only that you cannot, but it's dangerous to try, because you you start to think you know how to do it. You start to think, oh, I've had so much experience in medicine that I really know, you know. You just fool yourself. You are fooling yourself. And medicine is about going to hospital, is about getting better and living. It's not about going to hospital to die. I mean, maybe hospices, you go there to die because you know you've got something terribly advanced. But going to hospital is something about, you know, going to get better and live. So it should not be there.
Yeah, and the elderly now we seem to be returning to Victorian times, where the elderly are actually afraid to go into hospital for, you know, a knee operation, for example. They are terrified of going in, about what might happen to them once they're there.
Quite right. You know, and you don't have to be so elderly. I mean, I'd be scared to go into a hospital, frankly. If I had a fever and I had some sort of infection that looked a bit like COVID, you know, want to go in.
I mean, just picking up on the point you made there about, you know, it's been extremely difficult to determine with any degree of certainty when someone is likely to die. And, you know, you say it's scientifically erroneous to base any medical treatment on a prediction. And,
Right.
you know, I totally agree with you. And would you agree, by extension, that it's erroneous to base decisions as to whether to withdraw treatment on the basis of a prediction? And this brings me to the case that we have been following recently of the lady who died at University College London Hospital after being starved to death for 53 days.
Definitely.
And
Those
7 days
cases.
hydration. I just finished the case for the people that don't know the case. So this lady was taken into hospital in October with a stroke, and she had some mini strokes while in the hospital. But she was taken off a ventilator. She was breathing herself independently, and she did have a tube, an NG tube for feeding, and something went wrong, and they withdrew that, and they refused to offer any other alternative means of nutrition. The family complained and said, you know, that they didn't want their mother to be starved to death. And they took it to the Court of Protection. Now, the Court of Protection, and it should have been the hospital, but the hospital sat on it for weeks. And so the lady was deteriorating all the time. By the time it gets to the court then decides that it's now in her best interest to dehydrate her to death for 11 days. So these are medics making decisions, you know, and deciding that somebody's going to die, you know, in this case, nearly 2 months before they did, you know. And that lady, in from December until she died on February the 5th, had no, mid-December, had no nutrition. And they had decided, when the family said, you know, we don't want this to happen, the medics said, well, we're the doctors here, we're the experts, this is not your decision to make. And, you know, they also said, if your mother was in her 60s, we'd be treating her differently. This is terrible, you know, that
It's terrible. It is terrible.
So anyway,
so
thank you for that. So you would agree that this
definitely,
is highly wrong.
Nobody should try to make a prediction about death. And if you see an elderly person who's ill, who's got a fever, who's confused, the thing to do is, you know, give them treatment, help them to get better. I think, you know, reduction of treatment only occurs if you try treatment, it doesn't work. You try another treatment, it doesn't work. Person is beginning to not respond. Then you start to think, well, you know, should we be as aggressive as we are being in this case? Should we continue with antibiotics and that sort of thing? And if you start to do that, then you may do a phased, well, stop antibiotics. But personally, I would never stop fluids or nutrition. I would never do that. Now, legally, you're allowed to do that, and that was since I think it was the Tony Bland case that
Yes,
was
it was.
Judge Sloss. Nutrition and hydration were made medical treatments, and I think that's
Which
wrong.
is ridiculous, isn't it?
Everybody needs nutrition and hydration every day to live. So how can they be medical treatments?
Exactly.
There's something you have to give everybody every day. So
Yes, and I think this is something that the public is very unaware of, Patrick, because when we were posting on social media about this particular case, the public were coming back and saying, well, this is terrible, sure, this must be illegal. This is euthanasia. Euthanasia is illegal in this country. And they don't understand the precedents that have been
that's right.
make this legal. Outrageously so. So, the law does need changing around this.
It does. And also, in fact, it needs changing back because a couple of years ago, this law was introduced for taking away nutrition and hydration to people in long-term coma. And a lot of the medical bodies have signed up to this too, saying that nutrition and hydration can be taken away if you're in coma and your coma doesn't get better within a month. I mean, that's the new guideline, that it was within a month. And, it's totally inadequate. I mean, even people in coma can recover months afterwards, and they just need care and looking after. There's a hospital in London, the Putney Hospital for Neurodisability. All the patients in that hospital, well, many of them, they're wards with comatose patients who they gradually look after. They give them physiotherapy, they give them stimulation, and so many of them do turn around and they are able to get them home. I mean, that's the way to be looking after these people.
I totally agree. I totally agree. And we've had so many similar cases being reported by families. And I look at the case of my mother, which is also, exemplifies this, because the second time they tried to put her on the pathway was after she was rushed to hospital needing an emergency operation for a hernia. And we spent 7 hours in the ambulance before we actually got in. We got in. She was very unwell, and they refused to
Just
operate.
waiting for a place in the hospital, were they?
Yeah, we were 7 hours in the ambulance waiting to come in. And we finally got in and waited hours and hours in A&E. And then they decided they weren't going to operate. And I said, well, do I have any, input into this decision? I have lasting power of attorney. I would like you to operate on my mum. And they said, well, sorry, no, that this is a decision we've taken, basically, and it's too risky. And I said, well, what is the alternative? And they said, well, she will, she's going to die in the next couple of weeks. She's got a blocked bowel, and we'll make her comfortable. And when I heard those words, make her comfortable, because I knew what they meant by now, which means basically fit her up to a syringe driver, I said, no, she's coming home. We got her home. I looked up a diet on the internet, and my mum, I unblocked my mum's bowel and she lived another year, so.
It's amazing. It's an amazing story. But it just shows that, if you can't take things at face value. I mean, and you do have to fight. And home is often is the best place.
Yes, and we have
safest place is the safest place if somebody.
I believe so, Patrick, and of course not all families can take on that responsibility.
No, that's right. You can't have everybody taken home, particularly if they're really sick. But once the person reaches a stable level, if they're stable clinically, then I think home is the place quickly.
I mean, yes, my mum was, when I fought the case and got my mother home, on the discharge notes, it said 3 days to 3 weeks, and she lived 14 months, and arguably she would have lived longer if she'd been treated by the GP when I was calling them out because she had an infection. Turned out she had sepsis. They didn't discover it until 5 days later. She died. But my mum was a very strong woman, and this is it. This returns to our conversation earlier about, people, the hospitals, the NHS is not looking at the individual. They're looking at blanket policy, blanket guidelines, which are used almost like prescriptions, and they are not looking at the individual in front of them.
You're right. You're right.
Yeah.
And it's, you know, this is why I'm, having worked in the NHS for many years, I'm really quite pessimistic about the whole system. I mean, not that individuals aren't very kind and individuals aren't very talented, and some hospitals are superb, but the whole system, that it allows all these things to happen, that they bring in end of life care right across the board, to me is just unacceptable.
Well, and I'd agree. And, you know, as you said earlier, you know, hospitals are places where people should go to get better and return to their, you know, their former lives, or you know, maybe not former lives, but where they are able to enjoy the rest of their years with their family close by, you know, enjoy life. Instead, people, as we said, you know, are scared now to go into hospital because of what might await them. And this is a terrible indictment.
No, it's a terrible thing to worry not to go in. And I've had that from people. No, I don't want to go in. No, I don't. And you don't want to say, oh yes, do go in, because you know it's a sort of, anyway. So
I wonder if you could now, Patrick, if you wouldn't mind, look at the evidence that you have, that you were going to share with us on your slides at our event, but when I unable to do so. If you could talk us through the use of midazolam, and then we'll talk about the protocols. Thank you.
Just to introduce about midazolam and opiates, because midazolam is a drug that is used routinely in these end-of-life care pathways. And I don't know if you can see the slide, but midazolam is a benzodiazepine like Valium, but has a quick onset, short-acting, but is potent. And it has to be given by a syringe driver because it's short-acting. It does reduce anxiety and cause drowsiness, but it's not a painkiller. And its principal use in medicine nowadays is for conscious sedation, like removal of teeth, or short anesthetic when they combine it with a painkiller, and or for seizures, particularly seizures in children. The trouble about midazolam is because it's so potent, it's sedating, particularly in the elderly. And if given by a syringe driver, which means you continually give it all the time, it sedates somebody to the extent that they just don't do anything. They just sit there. They won't drink by themselves. They won't eat by themselves. So it is very dangerous. The other thing is that it is often, almost routinely, combined with morphine, which is an opiate. And if you look in the British National Formulary on the web page, it clearly gives you a warning that there is an additive risk of giving morphine or opiates with benzodiazepines, midazolam, because it causes respiratory depression. And particularly in a sick elderly person, it's dangerous, and it should not be given. And in reality, giving a combination of an opiate plus midazolam to an elderly sick person, to my mind, is criminal. I would never, ever do that. I mean, having looked after elderly patients and sick patients, the elderly and the sick, they're sometimes just on a knife edge. Their breathing is very, can be very sort of tentative, and you just give a little bit of a medication and you can just, suppress it. So these drugs, and they are pushed around, given in large amounts in these end-of-life care pathways. So those two drugs are bad. And I think the combination of them should actually be outlawed in end-of-life.
So that brings me to the question then, and maybe afterwards you can look at the use of midazolam during the lockdown period. But it brings me to the question of why on earth then when the guidance for rapid COVID guidance came in March 2020, NG163 as it was called, NICE Guidance 163, why on earth they would prescribe the two, give doses which were pretty high and many physicians have said are frankly dangerous. Why would they do that? And also, why would they then have the statement that was included in that guidance was, do not be afraid of using the two together, you know, because of worries about depressing respiration. I mean, they actually
the statement they had.
that.
I mean, that is, you know, that's criminal in itself, because, well, the story goes back to Liverpool care pathway, doesn't it? These medications were used in people with cancer who were dying of widespread cancer. And the main thing in, you know, the main thing in the main consideration there is that they don't die in pain. And it evolved from there. The fact that you sometimes gave morphine and sometimes they gave a sedative to settle the patient down, it became routine. And it's still an use of midazolam in end-of-life pathways is still an off-the-label indication. It's not, if you look at the label that you get, the little package insert with midazolam, it is not there as a recognized thing, but it is probably the main use of midazolam nowadays. So, you know, how can that be? It's given in a hospital, there's no evidence for it, it's not evidence-based, and yet it's handed out like water. So,
while being deprived of all, you know, hydration. Yeah.
Yes.
So
just problems with midazolam, just to go through this one quickly. Yes, the elderly and those who are debilitated are much more sensitive to midazolam and doses. And, you know, you've got to be very careful. But realistically, you know, I was always taught in, you know, medical school and in practice, never give benzodiazepines to elderly people who are sick, because just don't give it. Don't go there, because it depresses their respiration and you never know if you're going to just tip them over the edge. So here he's going quite the opposite, not don't, you know, be very careful or don't give it. Now you have, yes, give it. It's like we've forgotten all, you know, the lessons of medicine. It also, when a person is given benzodiazepine, they stop drinking, they become dehydrated. Dehydration leads to drowsiness too. If you're not drinking, you become drowsy. So that's the background. Now, if you want me to move to the COVID?
Yes, please.
All right. Well, this slide shows you, and I forget who was the person who actually found this out, but it came to light that there were two spikes. There were two spikes of midazolam use. Somebody asked for the
it was a freedom of information request.
That's right, freedom of information. And there were two spikes of midazolam use in 2020, 2021. In April 20, there were 38,582 prescriptions written, when compared to 21,310 in March and 17,991 in February. So they almost doubled in April. And April turned out to be the peak death month of the first wave of COVID. There were only 2 weeks where the death rate in care homes surpassed 8,000. And both of them were in April 2020, when there was a huge peak of midazolam use. And the worst was the closing week of the month, when there were almost 10,000 deaths. So, and compare that to the 5-year average, about 2,500 peak. So there you go. And the same thing happened then in January 2021, 27,636 prescriptions were written. And this was the peak death month of the second wave of COVID. And I can show you those peak, graphically that.
Yes, please do.
Okay, this was 2020, and this was all other deaths excluding COVID, and then in March, this huge peak, which actually coincided with that huge prescribing of midazolam. So, you know, you cannot escape the conclusion that many of these people were dying on end-of-life care because, as I said, the only other use of midazolam is very small in, you know, childhood seizures or given in for conscious sedation.
Mm-hmm.
So this is clearly what was happening.
Well, yes, I mean, my mother was in a care home in early 2020. And in April, in a 2-week, a 2-week period, 11 or 3 weeks, I think it was 3 weeks, sorry, in a 3-week period in April, 11 residents died. None of them were people expected to die. They were not in their end days or weeks,
Really?
or possibly, you know, some of them were pretty fit. They had dementia. But huge numbers, and that was in one care home in Ellesmere Port. But I know that that was pretty much the picture right around the country. And then, of course, following that, we had the discharge from hospital policy, which brought COVID into the care homes. So much for protecting the elderly. And of course, the other problem, of course, was, you know, when I mean, I think I mentioned this in our event, you know, back in January. When I called the care home, I was told there will be no ambulances, there will be no respiratory help, there will be no antibiotic, the doctors will not be visiting. And that was it. And basically they were thrown to the dogs. And that was the policy. And then you know, discharge patients into their homes, these were their homes, you know, was not only foolhardy, it was criminal.
Yeah, it's criminal. And then for these end of life pathways to be used on them. Yes, and no, very sad, very sad. And, you know, complete lack of care for elderly people, for individuals. You know, this is the thing, the individual's forgotten. And I think there was a lot of panic about, story came out that there weren't enough ventilator beds to go around. So, and I don't know if you've seen
Didn't
this.
we discover really that the ventilator was not probably the best for many of the patients that went into hospital? In fact, many died as a
A lot of
result.
hospitals had spare ventilator capacity. I mean, those new big hospitals that they created, what was that called? You know, the one out.
Oh, the Nightingale.
Nightingale, yes. They hardly used that at all. And same thing down at St. George's.
Mm-hmm.
During COVID, the ITU was never full. So
Mm-hmm.
anyway, this rapid guideline, COVID-19 critical care triaging, similar to what you had said, Amanda, about DNA.
Yes.
Yeah,
And
assess
also the
frailty.
resuscitation, that was the resuscitation, also the Resuscitation Council guideline for which showed a flow chart, is a DNR in place, and therefore the flow chart was then going to end of life care. And if the DNR wasn't in place, there was a treatment plan. So it was very, very clear, I think.
Yeah, well, this is very similar. If you're frail, you go down this side.
Mm-hmm.
And then if your critical care is considered not appropriate, and this is this is a very subjective decision, you know, whether the person, the age, what they look like, etc., etc. So the initial management was outside of critical care, and if the condition deteriorated, they put straight into end of life care. Now, this should never happen. You've got a sick patient in a hospital from a treatable disorder, and you're putting them in end of life care. That person needs treatment, whatever their age, whatever their initial frailty. Mm-hmm. And that's what the NHS is there for. But this is what happened.
Also, you know, the scale, I mean, so basically anyone, if you've got dementia, and depending on the severity of the dementia, I think it's a 6 or a 7. it meant that anybody that had dementia and had, you know, a condition was being immediately put on end of life, which was the case in my mother's case, and many
CFS score 5 or more, and and 65, over 65. I mean, who would consider over 65 as not being appropriate for care? So
well,
that's.
I don't know if you've seen the drama that's showing on ITV at the moment, which is called Breathtaking. But there's a scene in there where a medic is saying no resuscitation for the over 65s.
They said what? Sorry.
No resuscitation for the over 65s. Now, I don't know if that was actual policy, but and it's a drama, but I think that was reflecting what, you know, evidence there was.
Well, this is exactly what's on this frailty score thing. Patients aged over 65 without stable long-term disabilities use the clinical frailty scale, and then if 5 or over, which, as you said, is still somebody independent, but they could have illnesses, coexistent illnesses, then they tend to fall down here, don't they?
Yes. So you know what you know, what I'm also interested in is, you know, looking back at the LCP, and as you said, for a year it kind of went off that, you know, was not being practiced really. You know, the protocols and practices within the, you know, the LCP were not being used, and then suddenly they crept back in again.
Yes.
Do you know, so with or without guidance, do you think that the guidance is really being used far too prescriptively, and therefore is a danger? Because and also, do you not think that even if you were not to have the guidance, that the cultural mindset has already been established, and this idea that, you know, the elderly, they've had their innings, you know, they've had a good life, you know, we've got limited resources, you know, they shouldn't have the same access to treatment and care as the younger. We need to, you know, prioritize our resources. I mean, what do you think about that?
I think there is. I think there is a mindset. It's a groupthink that has crept into the NHS, whereby when somebody comes in, and it's the look of the person, quite honestly, that the person looks ill. And the trouble is, elderly people, when they get ill, they look terrible. You know, they do look really bad. But once you treat them, you know, they'll pick up very, very quickly, and they'll be back to normal in a couple of days. So it's like, you know, if you take somebody and you just look at them without carefully examining them, finding out and treating all the things that need to be treated, that's the problem about it. Medicine is treating. It's not just putting somebody on a pathway.
Well, yes.
Yes, and the other issue, just mentioned quickly, is the resources available in hospitals. You know, nurses are hard to come by. Beds, hospital beds, looking after elderly people is very hard work. And all of these things come together to push people down into that sort of end of life care kind of mentality. And also, you know, I think also important is that now hospitals are being run by managers whose bottom line is finance. It's not on making people better.
Absolutely.
And, you know, I think you have to have doctors and nurses running a health system, people who know and have dealt with sick people and have a vocation for that. It's a completely different thing to have to, you know, make sure that you're financially solvent at the end of the month.
Yes, I mean, one of the things that I found quite, no, I'd agree with that, and I think that, you know, one of the tensions that comes out in this drama that everybody's been watching, you know, in the first episode, is the tension between the managers who are, you know, just passing down the policy from on high, and saying, these are the new guidance, this is the new guidance. And the medics on the floor are saying, well, wait a minute, the people making this guidance, they're not here, they're not seeing what's going on. And I don't think hospitals were inundated. I think that, that is a bit of a propaganda issue on many hospitals were not inundated. But leaving that question aside, I think it's a very important point about the guidance. So the people on the ground who are actually living through what was happening, they should be the ones who are contributing, or not, who are interpreting what to do in that moment. And that could be forgetting about the guidance, because you have a new situation in front of you. You need, as a medic, to make your decisions on the basis of what you are seeing and the patient in front of you, not prescriptive guidance that is an ABC of basically how to, as we know, how to, end somebody's life.
So you have to see what's the matter with the patient. Is their breathing difficult? Are they on the right medications? Is the drip going in at the right speed? When you put somebody on end of life care, all of that is just forgotten. They put on the syringe driver. Most cases, they don't get fluids. And, that's not medicine. That's, it's euthanasia. Mm-hmm. Medicine is difficult, particularly in the elderly. Looking after them is time consuming.
I mean, as I looked after my mother 24/7 for 14 months and had 2 afternoons off in that time, I know how time consuming it is. But the problem is we have a social care system that is on its knees. People are not getting the care they need. Families are struggling. The artificial division between the NHS and, for example, continuing healthcare and local authority funded care, people are falling through the middle, and they're struggling to, on the NHS is saying, no, it's local authorities' responsibility. Local authorities says, no, it's the NHS's responsibility here. And, the family is left struggling, and many families having to, give up work to look after their loved ones at home because they have no choice. So the problem is, if we had a more integrated health and social care system, and people getting allocated the care that they need, rather than what is happening is people are not getting the assessments in the first place. When they finally get the assessment, they've deteriorated to the point that, of no return. Yes. And, they're ending up in hospital very quickly. And it's like a swinging door. They have a fall at home. They're back in the hospital. They don't get the care they need in the hospital. It's understaffed. And, they end up worse off sometimes than when they went in. And then they go back and they're discharged home, sometimes far too early. And the next day, they're back in hospital again. And it's just a vicious circle. There just seems to be no joined up thinking around this.
Yes, it's true. And it probably is also a question about availability of places outside a hospital. But I know it's certainly, the system is not working.
No, it's not working. I mean, it needs a total revolution, I think, in the way it's designed, managed, run, peopled, and regulated, However, what can we do then, Patrick? What do you think we, the public, can do about pushing back on these protocols and encouraging a different conversation around elderly care?
Yes, well, just about the pathways, I would say make use of midazolam and end-of-life pathways illegal, and stop any benzodiazepine opiate combination, because that's lethal. Just stop them. And the CQC has to play its part. The Care Quality Commission, they are supposed to be looking after safety in hospitals. Safety includes people not being killed off because they're considered to be end of life. They must require hospitals or care homes to notify all cases of fluid deprivation. If somebody's being deprived of fluid, we need to know the statistics. We need to know what's happening. CQC needs to know, and they need to come down very sharply on that hospital. As it is, none of this information gets through.
Or care home. because a lot of this has
Care
happened.
homes, yes.
And of course,
Nice
care homes
guidelines.
are very notoriously understaffed. You know, understaffing is written into the business model. So there isn't enough support for people.
Yes, that's right. Well, they have to be able to send patients to places where they have enough people to look after them. The NICE guidelines, which were set up in 2015, need changing because they still have on those guidelines that you can diagnose when somebody is dying, and that is the worst thing. That if you think you can diagnose somebody is dying, you're fooling yourself. However clever a doctor you are, you cannot do it. The reason is because it's just a self-fulfilling prophecy. If you try and make somebody better, 9 times out of 10, you're going to succeed. Give them a bit of fluid, give them a bit of this, give them a bit of that, and they will improve. So you must never make a diagnosis that so-and-so is dying. Now, when somebody is really, if you've tried a lot of treatments and you've given them antibiotics and they're just not responding, you can see they're getting tired, in that situation, never, ever put them on a pathway, but you could start to gradually lower the level of care and see where it takes you. Some people actually start to recover, but in some people's cases, it's the way that the way that they're going. You take off those things, and in that case, if the person dies, it's a natural death, and you haven't, been responsible by dehydrating. And don't ever dehydrate. Don't ever stop fluids, and don't ever stop the nutrition while the person is taking it. And there is the best interest group practice of the people are often put on end-of-life care pathways through a best interest group. And this best interest group is made up of nurses and carers and doctors as well, who are included in the patient's care, therapists. And the best interest groups makes a decision that the person should go on end-of-life care. The relatives, by the Mental Capacity Act 2005, the relatives were taken out from a preferential role, and so was the doctor. And those two things were unnecessary and wrong. The doctor has the experience and has the vocation and knows the patient, so why take them out from a key decision-making position? The relatives as well, they know the person.
You're referring to the family. Well, yes, and the family often knows the relative very well, and yes. I look at my mother's case. I mean, 3 times I was told she was dying. She wasn't dying. I knew her, and I knew she was.
Exactly, you knew. And you asked me to mention this about Lady Hale's conclusion, and this was Julie James, yes, from Liverpool. She has actually been through this with her family, and she went back to court and went up to the High Court. And Lady Hale, in the end, made a conclusion that relatives need to be part of end-of-life decisions. And that was a very important statement that was made. And I'm not a legal person. I don't know if they call it a precedent, but basically that conclusion should be applied throughout the NHS.
Yes, and I think, I had a previous conversation with you, didn't I, Patrick, where I said that this is actually contained in the as far as I'm aware, and from what I've understood and read, in the NHS's own constitution, that the family should be involved in end-of-life care decisions. And yet, in the case of the lady at UCLH, the Hindu lady who was dehydrated and starved, sorry, I've lost my thread there. Yes, the family.
The family weren't allowed to.
They were not allowed, and not only that, the family were told it's not appropriate for you to be making It's not appropriate for you to be making this decision And, we are the medics, and we know what we're talking about, and we know what's best for your mother, and it's not appropriate for you. And we are helping you. The impression, what they were saying was, we are helping you out of, allowing you to be removed from this difficult decision.
They think that people are going to listen to them, and they say, that they know they're killing off their relative, and they say you don't know what they're, it's unbelievable. It's like 1984, whatever. It has to be stopped.
Yes, and as we said before, a court of protection that is supposed to protect the fundamental right to life, if it is making a best interest decision to end somebody's life through dehydration, which is a torturous death, it really is very Orwellian, very Orwellian. And I think that we, the public, should be pushing back against this. So
yes, definitely.
Where do you think the
public outcry?
Yes, where do you think the public, because a lot of the public are not aware of what's going on. Not everybody's on social media, of course, but how do we reach out to the public?
Well, this is a key issue. Part of the thing I've found is that often the relative is quite elderly. They don't want to cause trouble. They have had so much emotional upheaval by their relative dying. The last thing they want to do is to start up a case. But there have been a lot of brave people who have tried to do this. And I know several that I can say, and some of them had terrific energy. But, they meet wall after wall after wall. And it's like the coroner, the police, they go to the police station, they go to the hospital, they meet wall after wall. What is it?
It's exactly the same in this family's case. The hospital sat on this decision that they'd made. The family said they wanted to refer into the Court of Protection. That was under our advice. The hospital came back after a very long delay, said, no, we don't see it's necessary. The family then had to take it to the Court of Protection themselves with no legal representation, not knowing how to approach the whole situation at all, totally, lost, and then end up in the Court of Protection, and the judge finds in favour of the hospital. So there's the lady is dehydrated, but then when the family said,
by that time she was so far down the road too. Anyway, she'd been going for weeks.
But when the family said, we want this to refer to the coroner, the medical examiner said, I've referred it to the medical team. Well, what do you think the medical team's going to do? It's going to cover up, what it's done wrong. And it's not the medical examiner. It's supposed to refer to the coroner. So the family then had to refer to the coroner, and they are still now, the coroner has now rejected an inquest on the grounds that there's not enough evidence and nothing to see here. So the family will be.
It's unbelievable, isn't it? It's unbelievable. The way forward, I think, groups like yours are very important, and they are several around the country, and pulling forward, getting the momentum going, getting it back into the papers, making goals and pushing for them, and not taking no for an answer. And I think and younger people getting involved, because the elderly, like I said, they get tired, their relatives died. But, if these groups start to coalesce, and again, Julie James has done a lot through her member of parliament. And I think things are moving.
I think the public is becoming more aware. And I think, the thing is, we know that these protocols were working, under the radar ever since, within very short time after the LCP was banned, as we discussed before. But during the pandemic, these protocols, and with the introduction of 163 and 191, they have set precedents that have kind of established this, kind of cemented it in stone. And we need to, get rid of that. And we do need the public to be pushing back. We need the public on our side, because if journalists and our politicians do not see the public making a fuss about this, nothing will be done. And I think that we need to be questioning our politicians and our prospective candidates, you know, in the upcoming election, about where they stand on social care, health, but particularly end of life pathways.
Yes, so I think that's a very, very important point, very important. And so for a couple of last things to suggest as well, a couple of doctors and myself made these end of life care Bill of Rights.
Very useful.
There are 10 things like, you know, sufficient fluids will be given, pain control is important, no sedation unless it's specifically discussed, right for a second opinion, involved in all medical and nursing decisions, and no DNR. These, I think, they're just fundamental things that should be on the wall of the wards, and people should be able to have these rights.
Well,
and then,
one would hope so, wouldn't one?
Yes,
but my fear is that, as you said before, unfortunately, the culture is so entrenched now that would they agree for these these guidance, you know, this to be on their walls?
well,
you know,
now they wouldn't. But
so.
I mean, if we keep pushing at a certain point, please God, there will be an ability to slip this in and say, look, we need this.
Yes, and I'd agree. And also, you know, as I said earlier, we are putting together some guidance for families of what to look out for and how to avoid their own loved ones being pushed down these death pathways.
And then just to show you this Dehydration Lifeline website, dehydrationlifeline.org. It shows you how to diagnose dehydration. This is the skin ridging test. It's quite easy to, and if you do it on your relative, you find this, then you have to, you know, the nurse has to come in and make sure.
I mean, I used it. I mean, I showed the carers in the care home that my mum was deeply dehydrated, and they just refused to accept it. You know, because who am I? I'm a family. You know, I'm not an expert, am I? You know, but yes, this is all very useful, and for families, because families need to know what to look out for and how to prevent their loved ones being, as I say, sent down these pathways. Thank you very, very much, Patrick.
Welcome. Well, thank you for inviting me, and it's so important, and keep up the good work. And, you know, we will get there.
Thank you. And just to say to people who are still listening with us, that we, you know, very much encourage you to have a look at the event that we held in January. We will have the link to that event up on the screen. And also we had a follow-up with that with Andrew Bridgen, who also talked about some of the things that we, the public, can be doing to push things forward. And one of those was a parliamentary petition. Perhaps there is one already out there, but not a parliamentary one. And I think that would be very useful. But there are many other things that we can be doing. I think that we need to be engaging more on social media about this, because the media is refusing to cover these stories. We need to get this out there to the public. But we also need, in our own communities and our own family groups, to be talking about this and making people aware of what's going on and how we stop it. So thank you, everyone, for listening. And thank you again, Patrick. Thank you.
You're welcome. Bye then.